Mr. Chairman, ladies and gentlemen, I thank Dr. Saad Mahdi to allow us to use his platform to give you this few talks about a lot of vascular charging program that we have set up in order to teach you a lot of tricks. Today I'm going to talk about something completely different than what you have seen before, the role of negative pressure wound therapy in refractory non-healing venous leg ulcers. People hate leg ulcers, but a lot of patients are suffering and we need to find something. And what I'm going to show you today is a lot of work that I have done over the past 30 years of my life, and I'm trying to deal with it. It's fantastic what we have achieved, and I'm going to give you the know-how so that you understand the basis of the problem and how we are trying to solve it.
Chimp 9. Here she's casting at what is called the Lucas tower, the object of which is to move the tower from peg to peg without placing a larger block on top of the smaller. As expected, she was unable to complete the puzzle at all. Then, we gave her what we call ALZ-112, a gene therapy that allows the brain to create its own cells in order to repair it. In biology, this is called neurogenesis, ureagenesis. We call it the cure to Alzheimer's. There have been absolutely no side effects associated with 112, with one exception. For some reason, the chimp's irises exhibit plexi green. Actually, we first noticed it in chimp 9, hence her nickname, Bright Eyes. We'll see when we bring her in. In theory, this therapy can be used to treat a wide range of brain disorders. It's virtually limited, as are the potential profits, which is why we are confident that you will vote to approve human trials.
So, as everything happening now, human trials becoming the norm. However, we are taking the COVID-19 without human trials, and hopefully it will prevent us from having the infection. But everything is moving so fast, and this is how I will show you today. Over the past 30 years, the only difference from doing the bilateral above knee amputation for all these patients is one thing: the pixelation of my camera. That's the only thing that have improved. However, we're still doing bilateral above knee amputation for our patients who are coming in with problem that's unsolvable. And that's the problem. We need to find other solution than doing the amputation. We need to regenerate tissue. We need to think outside the box. And this is what we need to think and perform for all these patients. Novel technologies. Hyperbaric topical wound oxygen therapy, to which I have the biggest center in Ireland doing this. However, still a lot of people don't believe in it. Negative pressure wound therapy. I've created the biggest center again. Still people don't believe it. Therapeutic ultrasound topical laser. I myself don't believe in it because I have done the trial, didn't work, but people said it's going. Autologous platelet-rich plasma, people believe in it. I've tried, it did not work. Transdermal cutaneous oxygen therapy. I've tried, it didn't work. The only thing that I believe in it is number 1 and 2. Hyperbaric topical wound oxygen therapy and negative pressure wound therapy. Don't waste money when dressing leg ulcers. This was done by Sultan and McCollum, and very clearly said that whatever you put, it doesn't accept compression. We are using the maggot therapy to clean the ulcer, and it's back to the future. So we are in the 21st century and still getting maggot to clean the ulcer to improve the outcome. And basically, the nurses don't like it because we're using maggot, but trust me, it cleans the ulcers without the patient going to theater, and it saves a lot of legs for us. Clinical evidence, venous leg ulcer. Let's try to define the concept that you understand. Compression heal more ulcers compared with no compression, and effectiveness depend on skill of the nurses. That's 100%. Pentoxifylline, which is Trental, increasing ulcer healing, proven in randomized controlled trial. There is no evidence for therapeutic ultrasound, which I've just told you. Superficial vein surgery, to which have been offered in a lot of patients, which doesn't make sense. Skin grafting, 90% been lost. Ulcer laser treatment doesn't work. Foam therapy doesn't work at all. In fact, it could cause a pulmonary embolism and blindness and stroke, or advice to elevate the leg or increase activity. Compression reduces recurrence and must be worn for life. Superficial vein surgery, the only thing that they discovered that it could do, it could reduce recurrence, but does not heal the ulcer. In here, the randomized control trial and cost-effective analysis of silver denoting antimicrobial dressing for venous ulcer. I have a t-shirt in Galway. I hate silver dressing. The Vascular trial was very clear. Using a silver dressing, it took 101 days to heal 3-centimeter ulcer, and only 86% of small ulcer healed at 1 year with recurrence rate of 14%. First of all, I don't see 3-centimeter ulcer. Next, for all, that any patient that you use silver on it, they don't heal because you are burning the skin. And this is an example of burning the skin using the silver dressing. As I've told you, we criminalize the use of silver dressing because it burns the skin. Compression increases ulcer healing rate compared with no compression. Multi-component systems are more effective than single-component system. Two-component bandage system appear to perform as well as 4 layers. And this is through a very good Cochrane review. Another Cochrane review, dressing a topical agent, meta-analysis of 78 randomized controlled trial about the best dressing showed no evidence of any superiority. Silver dressing agent did not improve the healing of venous leg ulcer. Total waste of time. I usually tell my trainee, whatever you cannot put in your eye, you cannot put on the ulcer, because you will create mayhem for the patient. That's my experience with the topical wound auction or the 2-2 box. This has been constructed in a Galway with a startup. I don't have any shares in it at all. And we use it for ulcer. And it healed the ulcer without any sort of scarring. And the patient comes in, if it's MRSA positive, within 72 hours, MRSA status have been changed. Definitely the reason for that is because it affects the microbiome colonization, improve the microbiome, commensal healthy bacteria, and that's why it heals very well and rapidly healing for such patients. It promotes angiogenesis and epithelialization, enhances bacterial activity with synergistic effect on antibiotics. This is the ESCAR randomized controlled trial, and the ESCAR shows that surgical correction of superficial venous reflux in addition to compression does not improve ulcer healing rate at all. It could prevent recurrence after healing, but it does not improve ulcer healing. Moreover, this randomized controlled trial of early endovenous ablation in venous ulceration and the 2020 appropriate criteria and from the Interventional Radiology Society. In EVRA, early endovenous ablation of superficial venous ulcer reflex resulted in faster healing of venous leg ulcer and more free time from ulcer. Unfortunately, simplifying technology resulted in unprecedented, non-indicated use of venous intervention across the United States with a sudden increase well beyond 480% of previous rate of utilization. Negative pressure treatment reduced time to healing. There's no randomized controlled evidence on the effectiveness of negative pressure as a primary treatment for chronic leg venous ulcer. That's why I am creating the science. Median time to healing with Vasc therapy was 29 days versus 48 days in controls. Wound bed preparation was shorter, 7 days versus 17 days. What are we missing in management of refractory venous ulcer? Proper compression dressing will resolve the perfusion defect. Active healthy granulation endures up to 3 weeks to develop. Dressing material cannot sway this phase except if they can attain the debridement daily. How can we speed up epithelialization coverage of a granulating wound? Disrupted enhanced technology. Vasc therapy for venous leg ulcer randomized controlled trial. This is the registration number. The Nile hypothesis is bridge back provides shorter time for complete ulcer closure when compared to gold standard of compression therapy alone. The Nile hypothesis to be tested is that there is no difference between both groups in terms of time taken for complete closure of index ulcer or till wound is judged suitable for skin grafting. So this is a patient coming in. We use the Watt software analysis to see pre-therapy. You can see that when we done the analysis, Watt fiber is 46% and necrosis is 53% and granulation tissue is 0. Then we start using the compression therapy. A high stiffness compression system produces large fluctuation in pressure during movement, producing great improvement in venous blood flow. Pressure peaks cause intermittent squeezing of veins and muscles that enhance venous return and calf muscle pump action. inelastic high stiffness compression system is superior to elastic low stiffness compression system. So we have two things, a macro strain and a micro strain. The physical response of the macro strain, it draws the wound edge together, remove the exudate and infectious material, reduce edema and promote perfusion. A biological response, which is the micro strain, it creates tissue micro deformation and cell stretch. Its cell stretch lead to cell migration and proliferation that result in formation of granulation tissue. So this is the whole mechanism behind the bridge vac and compression therapy. So the bridge vac and compression therapy. So the first thing it do, it draw the wound edges together. It removes the infection material. It reduces the edema and promotes perfusion. And then the black foam contact with tissue under negative pressure creates tissue micro deformation that leads to cell stretch. This cell stretch under negative pressure stimulates cellular activity that results in the granulation tissue formation that allow bridging and faster healing. That's why when you put the bridge vac and compression, you find that in the first couple of days, it's delayed, and then suddenly the healing goes exponentially very fast. And this is the best way to deal with such patient, the way that we have done it, using the black foam over at least 3 to 8 weeks. So the study design, randomized parallel group active control trial to compare effectiveness of bridge vac therapy combined with compression dressing to compression dressing alone. Randomized in 1-to-1 ratio, treatment administered for 12 weeks or until full ulcer closure, follow up for 12 months to determine ulcer recurrence rate. Bridge vac is combined with compression versus compression alone in non-healing venous ulcer is randomized controlled trial. Inclusion criteria: patient with refractory chronic venous ulcer for at least 6 months or more, venous ulcer is greater than 10 centimeters in surface area, age 18 years or more, and CPO C6. Secondary endpoint: proportion of ulcer fully healed after 12 weeks, degree of reduction in ulcer surface area, elimination of bacterial colonization at termination of the therapy, pain score, and 12 months wound recurrence rate. So this is the what we have done for the patient. So this is the patient. You can see in here is the co-band, underneath is the vac suction. Over there, they're fully mobile and they go in and out of the outpatient clinic. And this is the demographic of the patient, and you can see that almost 40% were MRSA positive. And you can see this is SEEP classification, all of them are SEEP6S. And previous treatment, everybody had between endovenous ablation, between SFA ligation, long surface stripping, multiple compression, local dressing, and no compression. And this is the ulcer surface area, and you can see that a lot of them are bigger than expected. They are almost all of them above 15 centimeters square meter. 42% of participants were suffering from an ulcer larger than 30 centimeters square. Duration of the ulcer: all participant patient had chronic non-healing ulcer of at least 2 years duration, with 48% of the participants enduring an ulcer for more than 5 years. Time to full healing: the longer the duration the participant had the ulcer, the longer time to full ulcer duration. We had some people who had the ulcer for almost a couple of years, but they have been managed by different types of treatment. However, as you can see, that ulcer showing signs of healing in 4 weeks were 76% versus 47% in compression alone. Time to full healing, as you can see in here, time to full healing, patient who had duration of ulcer 2 to 3 years took 74 days to heal. 4 to 5 years took 67. Patient who had an ulcer for more than 20 years took less than 4 months to heal, which was statistically significant. Bridge vac participant experienced shorter time to ulcer healing than compression alone, regardless of the duration. Time to full healing, again, ulcer managed by bridge vac took a shorter time to heal compared to compression alone, regardless of the initial size at presentation. And this is the Kaplan-Meier. Bridge vac participants experienced only 2 clinical infection episodes that required a total of 13 days of hospitalization and antibiotic therapy, as opposed to 7 episodes with 44 hospitalization days within the compression group. Total cost of bridge vac participant was 62 euro compared to 25 euros for compression alone. However, after factoring cost of debridement and hospital stay, total cost became 80,000 euro for bridge vac opposed to 88,000 euro for compression alone. And this is a patient came in with an ulcer, as you can see in here, as time goes by, 1 week, 2 weeks, 3 weeks, 4 weeks, 6 weeks, 7 weeks, 8 weeks, 9 weeks, fully healed. Bridge vac is more effective managing refractory, non-healing venous ulcer with reduction in time required for healing, with less recurrence rate and superior quality of life. It's great to be in Galway, and we'll be looking forward for your visit if you wish to see what we can do for our patient. Thanks so much for the opportunity to present.